Hello everyone, and welcome back to Rapid Review Rounds. Today we're covering a classic topic in hepatology that is a favorite on board exams, primary sclerosing cholangitis, or PSC. So, you see a young man with ulcerative colitis who presents with fatigue and a persistently elevated alkaline phosphatase. What should be at the top of your differential? Let's dive in and break down everything you need to know about PSC for the MCCQE1. First off, what is it? Primary sclerosing cholangitis is a chronic, progressive cholestatic liver disease. The key words here are inflammation, fibrosis, and stricturing of both the intrahepatic and extrahepatic bile ducts. And who gets it? The classic demographic for PSC is a young to middle-aged man with the average age of diagnosis being around 40. The single most important association to burn into your memory is its link with inflammatory bowel disease, IBD, specifically ulcerative colitis. About 70 to 80% of patients with PSC also have UC. The pathophysiology isn't fully understood, but it's thought to be an immune-mediated process. In a genetically susceptible person, some environmental trigger, perhaps related to the leaky gut of IBD, causes the immune system to attack the bile duct epithelial cells. This leads to a characteristic periductal inflammation. As this becomes chronic, it lays down concentric layers of scar tissue around the bile ducts. This is the pathognomonic finding on biopsy, onion skin fibrosis. This fibrosis causes the bile ducts to narrow and form strictures. Upstream from these blockages, the ducts dilate. This cycle of damage leads to cholestasis, or impaired bile flow, which ultimately causes progressive liver fibrosis, cirrhosis, and liver failure. How will these patients present? A huge number are actually asymptomatic at diagnosis and are only discovered because of abnormal liver enzymes on routine blood work. When they do have symptoms, the most common ones are profound fatigue and pruritus, which is severe itching. Jaundice and right upper quadrant pain are typically later findings as the disease progresses. And remember that strong association. Always ask about symptoms of IBD like bloody diarrhea. Patients with PSC are also at a significantly increased risk for some very serious cancers, most notably cholangiocarcinoma, but also gallbladder and colorectal cancer. So, how do we diagnose it? It starts with the labs. You will see a classic cholestatic pattern, which means a disproportionately elevated alkaline phosphatase, often 3 to 5 times the upper limit of normal. GGT will also be high. But the gold standard for diagnosis is imaging. The first and best test is an MRCP, magnetic resonance cholangiopancreatography. It's non-invasive and will show the hallmark finding of PSC, multifocal strictures and segmental dilatations of the bile ducts, giving a classic beads on a string appearance. An ERCP is more invasive but can be used for therapy, like dilating a dominant stricture. A liver biopsy is not usually needed for the diagnosis itself, but if done, it will show that periductal onion skin fibrosis we mentioned earlier. A quick note on serology. Unlike its cousin PBC, there is no specific diagnostic antibody for PSC. P-ANCA might be positive, but it's not specific enough to be a primary diagnostic tool. This is one of the highest yield points for your exam. Currently, there is no effective medical therapy that has been proven to slow the progression of PSC or improve survival. Ursodeoxycholic acid, or UDCA, may improve liver enzymes, but it does not change the long-term outcome. So, management focuses on 3 things. 1. Managing symptoms. We use cholestyramine for pruritus and supplement fat-soluble vitamins A, D, E, and K as needed. 2. Surveillance. This is critical. Because of the high risk of cancer, these patients need annual surveillance for cholangiocarcinoma with imaging and CA19-9. They also need regular DEXA scans for osteoporosis and, if they have UC, yearly colonoscopies. And 3, definitive treatment. The only curative treatment for end-stage PSC is a liver transplant. All right, let's put it all together with a board-style question. A 35-year-old man with a 10-year history of ulcerative colitis presents for his annual review. He feels well, except for some mild fatigue and generalized itching for the past few months. His routine blood work shows an alkaline phosphatase of 450 units per liter, which is normal, less than 120 units per liter, an ALT of 80 units per liter, which is normal, less than 50 units per liter, and a normal total bilirubin. What is the most appropriate next step to confirm the suspected diagnosis? A. Anti-mitochondrial antibody, or AMA testing. B. Liver biopsy. C. Magnetic resonance cholangiopancreatography, or MRCP. D. Start treatment with ursodeoxycholic acid, or UDCA. The correct answer is C. MRCP. Let's break it down. We have a classic demographic, a young man with a history of ulcerative colitis. He has symptoms of cholestasis, fatigue, and itching, and the labs confirm a cholestatic pattern with a markedly elevated ALP. This picture is screaming PSC. The non-invasive MRCP is the gold standard next step to visualize the bile ducts and confirm the diagnosis. To finish up, let's quickly touch on the differential and summarize the key takeaways. The main condition to differentiate PSC from is primary biliary cholangitis, or PBC. While they sound similar, they are classic opposites on exams. Remember, PBC is a disease of middle-aged women, while PSC affects young men. In PBC, the autoimmune destruction is limited to the small intrahepatic bile ducts. Also, PBC has a highly specific diagnostic marker, the anti-mitochondrial antibody. Another key difference is treatment. Unlike PSC, PBC responds very well to ursodeoxycholic acid, which is the first-line therapy and can significantly slow disease progression. And that's primary sclerosing cholangitis in a nutshell. Just remember the key takeaways. PSC is an inflammatory fibrosing disease of the intra- and extrahepatic bile ducts that classically affects young men with ulcerative colitis. They present with fatigue, pruritus, and a high ALP, and are diagnosed with an MRCP showing beads on a string. The only curative treatment is a liver transplant, and you must always watch for the high risk of cholangiocarcinoma. If you found value in this, please hit that like button and subscribe for more high-yield content. I'll see you in the next review.